Hello everyone, let me take you through the headlines of this month. The first one is about type 1 diabetes, and we always scratching our brains that what causes type 1 diabetes. Today we know that it's an autoimmune disorder. There is a mechanism called molecular mimicry where our autoimmunity detects a foreign antigen on the pancreatic beta cell. One foreign antigen that has been recently discovered is called as the hybrid insulin peptide, or as we call it HIP, and this continues to be on the beta cell long after diagnosis of type 1 diabetes. So this just featured recently. Another very important study which featured was about the gut-brain axis, and today we are somehow coming to a conclusion that probably the gut plays a very, very important role in chronic metabolic disorders like diabetes and obesity. The proof of concept has been that whenever we have treated people with obesity with either a Roux-en-Y or any kind of metabolic surgery, what we have seen is that majority of the remission of diabetes or remission of hyperglycemia occurs because of the gut-derived hormones, and they play a very, very crucial role. Today we know that there's GLP-1 and GIP-1, but there are many more gut-derived hormones which are coming in and will play a very, very important role. This just got published recently, last month, in a very high-impact journal. Another very important discussion and an article which came out from Dr. Arora this month talks about oral semaglutide and its actions on diabetes and obesity. Now, we all know that in people with diabetes, it's very difficult for them to lose weight. And here you have a drug like oral semaglutide, which has shown close to 5% reduction minimum in majority of people, and 1 to 1.5% reduction in HbA1c at a baseline HbA1c of 8%. So this and a GLP-1 in an oral form actually removes the hurdle that all of us have ever had about using GLP-1, because in spite of guideline directed management that we need to use GLP-1 very early, not only in people with atherosclerotic cardiovascular disease, but patients whom we want to make them lose weight, we want to make them prevent weight gain. Here also we are not able to use because of it being an injectable. We know that glucagon, you are not able to use glucagon so much when there is hypoglycemia, purely because it's unstable. And you have dasiglucagon, which is in a liquid formulation, and this has been used in postprandial hyperglycemia and post-bariatric patients who have undergone Roux-en-Y bypass, the dumping syndrome and postprandial hypoglycemia which occurs. Dasiglucagon has been used and has been shown wonderful results. So in future you may have this dasiglucagon for treatment of overall hypoglycemia in a liquid formulation. Today we know that glucagon comes in an injectable. Recently there was a launch of nasal glucagon in the US. We may have nasal glucagon coming in here, but again, if we have something in a liquid formulation, it would add to our armamentarium in treating hypoglycemia. So let me welcome the guest of this month, which is Dr. Jayanta Panda. He's a very close friend of mine, and there he comes. Let me welcome him. So let me introduce the guest for this month's edition of Diabetes News Nucleus. Very close friend, Dr. Panda. He is also the head of medicine professor at the SCB Medical College, Cuttack. He is also the chairman of API Odisha. A man who is as humble as you can see, and he looks like a rock star, but very, very humble person and a very nice human being. Thank you, Dr. Panda, for being with us. Come. Today we are going to discuss a very important topic, because Unfortunately, in diabetes, we know there is microvascular complications and there's macrovascular complications. But sometimes patients come to us many a time with infections. You know, infections has now become a part of complications of diabetes, especially type 2 diabetes. So why do you think that patients with diabetes or people with diabetes are more prone to infections? Are they immunodeficient?
Very nice point here put forth. Right. Many people don't know that more than the cardiovascular, microvascular or macrovascular complications, people die here in infection. As per data from PGI Chandigarh, almost 45% death rate in diabetics are from infection. And then we think that infection is a very simple thing that we will control because many developed countries they don't have infection.
Sure.
But we have tuberculosis, we have chronic diseases as well as the acute infections very well spread over the country. And India really faces the brunt of infection. To answer your question, why infection in diabetes? The number one is the blood sugar. Whatever medicines you give or insulin give, where the people they have very high blood sugar at some point of time in the day. If we take a continuous glucose monitoring, you'll see that level fluctuates and blood sugar goes high. And then that is the food for the bacteria. So the bacteria, the virus, the parasite, the organisms get extra food from the high blood glucose of the patient that attracts them. And there are few host factors as well. That is the number one immunodysregulation. And most important thing, the cell-mediated immunity, the humoral immunity gets deranged because the neutrophilic activation, the antioxidant system, and overall the action of phagocytosis and killing the bacteria, the virus is jeopardized because of a hyperglycemic environment.
This is something that patients actually don't understand.
Yeah.
And they feel that why am I getting an infection, and why is my colleague who's not a diabetic not getting an infection? So, which are the common infections you find in your practice as such? Because all said and done, as you were saying, India unfortunately is a place of the overfed and the underfed. The underfed also has diabetes, overfed also has diabetes. You have diarrheal deaths and you have deaths due to cardiovascular disease. So it's quite a irony of things. So why do you think that? What are the most common infections you see in that?
This is a very important thing that you have raised. Uh, Infections like fungal infections we see very commonly. That may be a oral thrush, candida affecting mouth, who have a very ill maintenance of the oral cavity, denture, or chewers of the pond in this part of the world, and they have an increased incidence of these fungal infections. And other fungals like a onychomycosis, like a
Even
intertrigo,
dental periodontitis,
periodontitis,
all that is.
they're very common to start with. Second infection that we encounter very commonly is a urinary tract infection because women have a higher incidence. Elderly man with a large prostate or the obstructive uropathy have a predilection towards infections. Besides, there are few infections very specific to diabetics, like chlamydial infections by Haemophilus influenzae, by Streptococcus, by Staphylococcus, starting from the diabetic foot. And what happens when there is a microvascular complication and diabetic neuropathy, the perceptibility of the patient goes down. He cannot detect the foreign body injury, and as such, the vascular supply also jeopardized. So there is more chance that a diabetic foot will catch a ulcer and result in a foot infection, which ends in amputation. And few things are very common that I'll tell, which detects diabetes many times. Like patient presented with that infection, we suspected, tested, and got the patient diabetic. So that is one is the malignant external otitis, very specific, rhino orbital mucormycosis, emphysematous cholecystitis, emphysematous pyelonephritis. But
These are all atypical opportunistic infections we only see in people with diabetes. So tell me a little bit about diabetic foot. You head a department which obviously drains a lot of people across. The diabetic foot infections, you see in all classes. Even if you do an economic divide, is it because that people don't understand? Because a lot of patients ask me, diabetic hand nahi hota, diabetic foot. And so diabetic foot infection, how can a physician say that these are the high risk for diabetic foot, so that they screen them and educate them properly?
again, very pertinent question. We spend half an hour in our diabetic clinic to speak every patient regarding foot care. You see, hand is little above, but foot comes in contact with the surface every time you are walking and moving around. And awareness of our people regarding the foot care is very poor.
Very poor.
People don't look to the foot. There is a callosity, there is a onychomycosis, there is a fungal infection.
And we love walking barefoot also.
Barefoot also. There are many people who, even if offered, will not take shoes. And washing a foot, putting moisturizer, cleaning it after it gets wet is not there in most of the people in the rural areas and also illiterate background. So what happens? They have uncontrolled diabetes, already neuropathy and vasculopathy, jeopardized blood supply, and they don't know the injuries and the stimulus which is put in the foot, which increases, results in an ulcer, and when the ulcer is infected, they present in a very advanced state. Every week we have patients, we have diabetic foot section in the surgery department where we put them the months together, they stay for the dressing, debridement, and at the end many people have amputation. So simple teaching, what I'll point out here on the part of a diabetes consultant, simple inspection of the foot on the first visit and simple teaching of the foot care by the educator, that you have to look to the foot, wash your foot with warm water, put some moisturizer, dry it, and see that there is no callosity, no infections, no fungus, no injury. That will protect the foot for long. And as you told, footwear is a must.
Absolutely.
And for every diabetic, it has to be a fitting footwear.
Absolutely.
Or else somebody is having a charcot foot, somebody is having a diabetic neuropathy, and therefrom the ulcer starts and spreads around.
So, diabetic foot infection by itself can be a subspecialty of diabetes. As you have subphenotype, you can have a subspecialty of diabetes.
Already, you know that there is a Diabetic Foot Society of
Absolutely.
India,
Absolutely.
which is working only on foot problems.
Absolutely.
And there are medical as well as surgical and people from plastic surgery, people from cardiothoracic, they are also involved.
All involved.
All involved. We try to shape the limb, but unfortunately, the people's awareness and their reaction towards this simple habit of taking care of food is very difficult to evoke. I see hardly 5 to 10% people, they become conscious and they do that and they have very good food throughout their life.
I completely agree. When I was reading long back, I realized that you cover 80,000 to 90,000 kilometers in your lifetime. So your foot takes that kind of pressure all your life. So obviously it's a very high risk and high stress to cause any kind of problems.
And especially those who have a flat foot.
Absolutely.
Those who have
anatomical issues, we never. I think that is another thing, that we need to first tell doctors to remove the socks or footwear and at least inspect the foot. You can get a lot of information.
90% of the consultants don't do that.
Don't do that.
And we have mirrors to look into the
Underneath the
under surface of the foot. And at least if you ask the patient to lie down, see the vibration, see the jerk, at least ankle jerk. 90% patients who have neuropathy will be able to detect.
Absolutely.
And we can intervene at that point of time, which never happens. And ultimately, it presents in a very advanced stage and in an amputation and artificial limb.
And amputation by itself increases mortality. The 5-year mortality of amputation is pretty high. So we have to prevent amputation, whatever we have.
Yeah.
Another very most common uh, infection in people with diabetes is tuberculosis. And after 50, 70 years, also we still see, and in public hospitals also. Since you are the head of medicine there, I'm sure you come across a lot of people with diabetes and tuberculosis. So has it increased? Is it the same? And how do we approach this? This is a public health problem.
Very pertinent issue. Maybe 30 years back, the message was if a diabetic presents with fever, you must not leave him without a chest X-ray because tuberculosis was so common association. India has tuberculosis uncontrolled and India has diabetes uncontrolled. Another thing which creeps in is HIV. HIV tuberculosis is very common, and if a patient is diabetic at the same time immunocompromised, uncontrolled diabetes, because patients of diabetes, controlled and uncontrolled, have different story and different presentation. And those who have a very hazardous lifestyle, uncontrolled diabetes, and continued fever, that you must have a thought of the patient can be tuberculosis, and the workup must
A
contain
very high antenna and index of
suspicion, and we detect the tuberculosis infections and the fever persisting for more than 2 weeks in almost 60% of the diabetics that are there, and they also require insulin.
Are there any atypical presentation apart from chest? You see extra pulmonary manifestation of
Very
tuberculosis?
common. Second will be the lymph nodes that we see, mostly cervical and other groups like axillary also. Third is we have seen the cutaneous, we have seen the abdomen, we have seen the genitourinary, even we have seen the musculoskeletal. Musculoskeletal. And atypical tuberculosis mycobacterium is also not uncommon.
Okay.
So many times we go for the liquid culture, we detect tuberculosis, and if we fail from every front, we go for a empirically antitubercular course of treatment, which is highly responded by these people.
Sure.
So starting from the liver tuberculosis to the bone tuberculosis.
Very difficult.
Very difficult. But in the background, if there is diabetes, you have to keep it in your mind. They are the people who respond very well, provided we start along with insulin. Unfortunately, many physicians in the country still try with oral drops.
That's a very important message. So any infection patient to be on insulin, isn't it?
Yeah, and especially tuberculosis, because the antitubercular drops, they work through the hepatic P450 enzymes. If you give oral drops and the antitubercular drops, you don't expect an optimal response from these drops. So, very important message goes: we have to plan a antitubercular therapy with insulin. Whatever may be the situation, you have to convince the patient. You have to admit the patient for a long time, but insulin along with the antitubercular drops, at least in the intensive phase, is must for the antitubercular drops to work optimally.
And is the duration the same, or for diabetes, would you give for a longer duration? Is there any consensus on that? Or?
No, actually, in diabetes, the duration is same, but for different sites, we have different durations. Suppose it's a CNS tuberculosis. Many patients present with tubercular meningitis and bone tuberculosis. They present with pot spine and then present with the compressive lesions with Schwarz abscess. So in those patients, it's very vital that we give at least for a year, and if we alter the regimen, and if you don't tolerate the pyrazinamide or rifampicin, they have drug-induced hepatitis, they have renal issues, diabetic kidney disease, we are modifying the regimen. Maybe we have to go up to 18 months. So depending on the host background of the complications and the different issues related to the site of tuberculosis, the regimen duration varies. But for a common pulmonary or pleural tuberculosis, 6 months is adequate. Even abdominal 6 months is adequate. Only thing we have to be sure that the levels have touched the baseline, the ESR the ultrasound, the X-ray, the talks the best line.
Right. And you alluded to these opportunistic atypical infection like MBO and all. Tell us more about it. Tell us about these where a lot of physicians don't come across this and they need to know. If they don't need to know, they will miss the diagnosis of these things. Tell us something about it.
When COVID was there, many people were thinking the infection to be local orbital infection or nasal infection. But fortunately, at the end of the COVID, people on steroid, diabetics, and a long duration presentation of ICU stay had a typical rhinocerebral mucormycosis, and that opened the eye. And post-COVID era, my residents are diagnosing immediately, sir, we have a rhinocerebral mucormycosis, because there occurs the black secretion from the nose, swelling of the eye with visual defects, headache, and patient moribund. And this is so common because the mucormycosis is a ubiquitous infection, and when the diabetic is immunocompromised, uncontrolled, along with steroid for any cause, maybe prolonged hospitalization, and the proper asepsis is not maintained, they present, and that the issue is that it's very fatal, and primary management is surgical. So we have our mucormycosis ward in the ENT department, and then we have to go for surgery because out of all the varieties of cerebral, of GI, of cutaneous, most common is this rhinocerebral, and surgery saves the life.
Absolutely.
So antifungal, insulin, the debridement, all are required in priority now, and awareness has increased post-COVID. Initially, the awareness was very low of patients' diagnosis was missing. We have seen patients, but hardly people are suspecting.
But what about malignant external otitis? It's also very common, but a lot of people miss it.
Yeah, and malignant external otitis is classical of diabetes, so also a carbuncle.
Absolutely.
You must have seen
many
patients with carbuncle.
Carbuncles.
And that infection is so typically associated with
Diabetes.
Uncontrolled diabetes that we see and we tell the patient you have diabetes.
Like balanopostitis.
Yeah, balanopostitis. Balanopostitis is very common. The penile moniliasis and balanopostitis is a presentation from where you can confidently tell the patient you have diabetes. So I see and tell that you have diabetes. And patient tell, no doctor, I had diabetes. No time I had diabetes. And when you test, it comes out. Just a random or casual blood glucose you test and tell that it is confirmed you are diabetic now. And there, like in HIV, we have AIDS defining infections like Kaposi's sarcoma.
Yes.
Like many times we see the oral cavity, a widespread throat, the oral esophageal candidiasis, and we think of HIV. Similarly, if you get a malignant external otitis, the typical rhinocerebral mucormycosis, and balanopostitis, and infections like emphysematous cholecystitis or pyelonephritis, that indicates directly to the presence of diabetes, and that to uncontrolled diabetes. And many times I diagnose the diabetes, the diabetic ketoacidosis, and even they have come with hypoglycemia to me, because if they are on treatment and discontinued and diabetic kidney disease and long term, so they present with the complications many times. If you list this, and because we are in a developing country, because infection is very rampant, the message should go loud and clear to all diabetes consultants that micro and macrovascular is fine, cardiovascular is fine. We have many new things are coming up like non-alcoholic steatohepatitis, starting from the pulmonary to the hematological to the musculoskeletal, all complications of diabetes. But we can never dare to forget the infections.
So, Dr. Panda, about malignant external otitis, is there any hallmarks to it? Because a lot of people miss it, think that it's some common infection and put fungus and and it's dangerous infection. It's a life-threatening. Mortality is very high. So, what's the hallmark do you think? How would you diagnose it?
Yeah. The external ear or the pinna is very pain sensitive, and once there is an infection in the external layer. The first presentation is pain. The patient comes with the pain, redness, and swelling, and then the consultant never gives importance because he thinks that this is not a very important site or vital organ that he should embrace upon. And because of the mostly cartilaginous structure and fixed skin, they don't have lot of external manifestation except redness, swelling, and intractable pain. So that's the common presentation the patient comes with, and from that we have to watch, see what exactly happening, and as we have discussed, the rightly we have to test for the blood glucose and see if there is a issue related to diabetes and malignant external otitis, and try to control it at earliest. So it's not only fatal, it's very painful, and then patient runs to the doctor
Like
for
a
this
very high index of suspicion.
suspicion for that.
About necrotizing fasciitis, somehow it gets diagnosed quite late. By the time the mortality is very high, so I know it's very difficult to diagnose, but we should talk about it because you miss that, and if you don't debride early, patient is gone. So again,
Again, it's a very severe end infection in diabetes, and most commonly we see in advanced diabetic foot. A foot ulcer advances to the calf, to the upper part, even at times I've seen in the thigh,
right.
and the compartmental syndrome comes, and necrotizing fasciitis comes.
Right.
One important situation, when we get a scrotal infection which extends to perineum,
Right.
and it has also the necrotizing fasciitis.
That's right.
When we see early gangrene, we see blackish discoloration along with signs of inflammation, the redness and the swelling, and then this is again life-threatening, and many people request debridement, maybe in septicemia, and good antibiotic and good supportive therapy is mandatory. We keep surgeon as a partner in management of corneous gangrene, because that's another life-threatening fatal necrotizing fasciitis.
Again, high mortality.
Yeah, the perineum and the calf are the two areas which is extending from a scrotal infection or the foot infection and present with necrotizing fasciitis. And unless surgically intervened in time, the patient deteriorates, and it happens that we may not be able to save the life.
The patient. Now let's come to something which wreaked havoc for us for last 2.5 years, still wreaking havoc in our life, COVID. And COVID actually raised eyebrows across the globe, but a lot of patients with diabetes realize that they are the ones who had adverse outcomes. And then they realize retrospectively that diabetes is immunodeficient. So tell us your experience of COVID and diabetes. And in your hospital also, did you see the same trend globally that people with diabetes were having worse outcomes? They were not more prone to COVID, but they got more worse outcomes with COVID. And just hyperglycemia, was it only a risk factor for COVID?
It's a right issue post-pandemic that you have raised. We had almost 600 bedded dedicated COVID hospital in my medical college, and 62%. We had a systematic study of around 7,000 patients whom we followed in the first, second, and third wave, and 62% patients had hyperglycemia, and just 47% from them are non-diabetic, who had poor control because of different issues of stress, of infection, of poor nutrition, of steroid. But many, you can know that almost 15% people had new onset hyperglycemia, and for that we analyzed the causes. The most important cause we found, people had pancreatitis as well. Maybe the novel coronavirus target was pancreas, and even in patients with milder or moderate infection, the post-COVID diabetes was not uncommon.
Very true.
Second important issue we found, though the infection of COVID was almost at par with diabetics and non-diabetics. The outcome of the disease was very turbulent in diabetics. Most of them went to ICU. Out of the patients we lost, around 87% patients were diabetic. Though admission was around
That's a very huge number. The
Yeah.
patients you lost.
Yeah.
87%. So 9 out of 10 people who died.
died in they are diabetic.
Hmm.
So maybe 50-60% patients were diabetic at admission or had hyperglycemia. But if you see the mortality data, it's almost 90%. So one thing I can conclude from my center that people have high risk of hyperglycemia during COVID. So diabetes as such in news, and during pandemic also diabetes remained in news. And when patient had some comorbidities, most important is obesity. Diabetes with obesity, diabetes with diabetic kidney disease, diabetes with heart failure, COPD, patient with micro and macrovascular complications, malignancies, asthma. They are the people who require transfer to HDU, transfer to ICU, went to ARDS, booked on the ventilator. Even few people went for ECMO because we have 9 ECMO machines in our center.
Okay.
So, but still after 1.5 months, nothing could be done and they were lost. So the conclusion is, though infection chances of novel coronavirus was equal in diabetic and non-diabetic, the people with diabetes, especially with comorbidities like this, it is very turbulent course unless very well controlled and well managed from the beginning, number one. Number two, those who had recovered also had a very turbulent post-COVID or long COVID sickness. It's more than 1 year or 1.5 year by now, and we see features like dyspepsia, like insomnia, like new onset diabetes. Somebody has gained weight, somebody has lost weight, lot of hormonal abnormalities. And even the important message goes, which also corroborated by the publication across the world, that even mild moderate infection has presented with new onset post-COVID diabetes. So it has added to the new onset. Maybe they are now type 2 and very soon they can go to type 1 when pancreatic beta cell will be adjusted.
I think the whole pandemic has raised so many questions that we will take a long time to answer. And also a lot of it has highlighted the importance that there are a lot of metabolic abnormalities in diabetes. A lot of our patients believe that it's only sugar, and they don't know that it's more of a syndrome where, multiple organs and multiple comorbidities can occur in one individual, and out of which infections, people don't realize it. Doctors also don't realize it, and it's important that, today with the kind of knowledge you have given, with your own experience, because you come from a big tertiary center and you see patients from all strata of society, and that kind of experience sharing, I'm sure a lot of our doctors who are going to listen in today would feel extremely delighted, because they are getting, it is like in 10th standard we used to have those last minute revision before going. This was like a condensation of infection in diabetes. Thank you so much, Dr. Panda. Wonderful venue. This is a super venue and wonderful talking to you. If you have any, takeaway or take home message about how a physician across India, anywhere in India, can raise his antenna for infections. He screens for lipids, he screens for the kidney, he goes and screens for the eye. But he needs to know that infection is like hovering around, and you need to catch infection very early, because it can be very turbulent, as you said. Well, one last message from you before we shut.
That I want to tell to all metabolic physicians, because we are in India. If you see our in-hospital patients, more than 50% are diabetic, and they are admitted for infection. And I have already told, the issue is infection in majority whom we lose. If you go to the government hospitals, if you go to the corporate hospitals and analyze death, you'll see not only that they present with infection, they succumb in infection. And already we have data that infection is the cause for the largest mortality in diabetes in India. That message I want to give. And all metabolic physicians and the consultant diabetes and the metabolic practitioners should have it in mind. So, in the first interview itself, they have to tell the food care and healthy habits like water intake, like exercise, like the lifestyle modifications, which will make the patient immunocompetent with a good control of the diabetes and prevention of infection tips. That's a must. And from time to time and every visit, they have to see whether the patient has any risk for the infection. Like a patient has obstructive uropathy, anytime he can go to UTI. UTI can result in septicemia and multi-organ failure.
Absolutely.
Like an elderly lady with a maybe vulvovaginitis or the candidiasis can have a fatal fungal septicemia. And we discussed about typical diabetes infections.
Right.
So always we have to keep in our mind that though the infection is not listed in the primary complications, still in India
It is the biggest,
biggest issue, and we have to make the patient very conscious of staying infection free, report at the earliest, because the cause of death is the late reporting in many of the patients, and physician should have his eyes open to detect and treat adequately the infections every time he comes across such a patient.
Thank you so much. Thank you, Dr. Panda. Wonderful talking to you. Wonderful.
Thank you.
And I hope all of y'all who listened in today, got the gist of what we were talking. That infection in diabetes is a huge killer, especially in India. Keep your eyes open. Have a very high index of suspicion for a lot of atypical infections, which Dr. Panda spoke to you about. Thank you all for watching us on this 18th edition of Diabetes News Nucleus. We will be back with you next month with the headlines of next month and also with a key opinion leader in diabetes to discuss some other comorbidity or complication related to diabetes. Thank you all for a patient hearing. Thank you so much.